Okay, good afternoon, colleagues. We are very happy to start our webinar today. So the webinar today is part of the workshop about monitoring and evaluation of infection prevention and control practices and programs. So yesterday we had the first webinar, and today we'll have the second webinar in this workshop. So today we will discuss the IPC practice assessment tools in the context of COVID-19. Further on, I will present our speaker. And yesterday we discussed monitoring and evaluation of administrative measures for infection prevention and control. So if you didn't have the opportunity to join us yesterday, by next week, all the presentations will be in PAHO webpage. So again, welcome and thank you for your participation in this webinar today and in the whole workshop initiative that we are hosting since the beginning of the year, the infection prevention and control workshops. So some general information. It will be an hour and a half session. So we will have a 60-minute presentation, and that will be followed by 30 minutes of questions and answers. You can put your questions and answers on the QR tab that is you can see in your screen together with other tools, and your question will be answered by the end of the presentation. The webinar today will be in English, but there is a translation available into Spanish and Portuguese. So in the same bar where you find the questions and answers, you also will find a globe icon. So if you click there, you see the options for Portuguese and Spanish translation. So please feel free to choose the best language that is for you. And before we start and introduce our speaker for today, I would like to thank the translators who are making possible to us to understand each other and have the best of our sharing our knowledge. So I also would like to thank the team from HSS Pillar in the COVID-19 response in PAHO, Jimena Tejas, Maria Claudia Guzman, Soledad Urtia, and Raul Argueta, who work behind the scene to make possible that we met every month here to have this webinar. So thank you very much for all of you. And it's my great pleasure to introduce to you our speaker today, Ms. Catherine Johnson. So she's PAHO consultant for infection prevention and control. She has been working in many Caribbean countries, supporting the implementation of the IPC programs and also assessing the practices in many countries in our region. So Catherine, it's my pleasure to have you here today. So thank you very much for accepting the invitation. So you have an hour to share with us about the tools and your experience with this practice and the assessment. So thank you very much, and the floor is yours. Thank you.
Thank you, Valeska. It's a pleasure to be here today, and I'm really looking forward to the chance to share all of this information with everyone. If you will allow me a moment to share my screen. And it always gives me two screens to share.
Yeah, we are seeing it.
Excellent, excellent. So today I'd like to talk about the practical assessments of the IPC assessment tools in the context of COVID that we saw that we have seen in the last few years. So today, the key points that I want to make is we're going to talk a little bit about the assessment, about the methodology and the principles of monitoring that we saw. And I'm going to talk about how we planned and executed and then planned for the presentation of the assessment results. And we're also going to talk a little bit at the very end about some of the challenges that we face and also some of the recommendations that I have on a personal basis that may facilitate this process. So PAHO has been advocating for and conducting systematic IPC program and evaluations in hospitals and acute healthcare facilities since 2011, with the publication of the Rapid Evaluation Guide for Hospital Programs for the Prevention and Control of Nosocomial Infections, which was produced in both English and Spanish. In 2017, we know WHO published the guidelines on the core components of IPC programs at both the national level as well as the health facility level, with 6 components that applied to both levels, and then an additional 2 components that contributed to an enabling environment that supported IPC at the facility level. So the URL address on your screen provides additional references and guidance documents. It includes key publications, there's guidelines and evidence available. They have several implementation tools, they have training tools, as well as monitoring and assessment tools. And it also includes the WHO IPC Global Portal, which provides access to online assessment tools that can be utilized for instantaneous results, which can be saved, and the countries can then further conduct assessments that are comparable over time. Or for those countries that do not like to save their results, it can be used in what they call a sandbox feature, which allows all the information to be removed before the country leaves the site. But as I stated, along with the guidelines, WHO provides an array of resources that support this implementation process. And along with it are the practical guidance for the implementation of those core components. There's advocacy videos and scripts that allow us to sell the value of IPC programs to decision makers, as well as the assessment tools, which is going to be the focus for today's presentation. So in conducting these assessments, it's important to note that WHO advocates a continuous cycle aimed at implementation, at improving the implementation status toward the eventual achievement of a fully functioning IPC program. And this needs to happen in the concept of a multimodal improvement strategy that's embedded within each step. So assessing not only, but is including the assessment of the infrastructure that's necessary to support these programs, the training and education that's necessary, monitoring, which we're going to talk about more as we move through this process, and as you heard about yesterday with both Joao and Francini. So in order to achieve the assessments, it's important that programs, in order to achieve all of this, it's important that programs perform these assessments to determine their strengths. That is, what do they already have in place? And from there, what are the gaps that they have? And then that is where the efforts can be focused to achieve the additional gains over time. And it's important to note that these don't happen, that these happen in a hopscotch kind of fashion. So you may make progress in one area and not another, and then there will be a lull in that first area and you'll make gains in other areas. So it is all dependent on where the resources are available in which to apply them for sequential improvement. So monitoring and evaluation is central to the core components. And we've seen that in the actual core components themselves, with references for monitoring programs for healthcare associated infection surveillance, the multimodal strategies, and then of course, core component 6 is a standalone core component that is dedicated to monitoring and audit and its associated feedback of IPC practices and activity. In the context of COVID, we saw the consequences of IPC program gaps where we experienced outbreaks of COVID in healthcare facilities, and sometimes the need for IPC strengthening and IPC assessments. So as a result, the IPC assessment tools developed by WHO, both the IPCAT, the Infection Prevention and Control Assessment tool, and the IPCAF, the IPC assessment framework, were adapted in our instances for virtual methodologies and as self-assessments. And in the Bahamas and the Turks and Caicos, which are two of the English-speaking countries in which I had experience, we were actually able to adapt those for application in the outpatient public healthcare setting by focusing on PHC minimum requirements. So I want to talk next about the monitoring tools that were used and the adaptations that we made to those tools. So as I stated, the main tools that we used were the IPCAT, the Infection Prevention and Control Assessment tool, which is focused at the national level, and the use of the IPCAF, the Infection Prevention and Control Assessment Framework, at the health facility level. And this allowed program monitoring to be done at both levels within these in English-speaking countries in which I participated in the assessments. And it allowed them to compare progress over time, or if it was a baseline facility, it allowed them to identify the areas that required additional improvement. So we're going to speak first about the IPCAT tool. So the IPCAT was applied as an Excel-based program tool. It could be either self-administered or administered as a telephone interview, and it allowed the national authorities to document and measure the achievements that they had made or achieved in core component 1 through core component 6. And just as a reminder, the core components are core component 1, which is the IPC program, core component 2, which is IPC guidelines, core component 3 is education and training in IPC education and training, core component 4 is healthcare associated infection surveillance, core component 5 is the use of multimodal strategies for the implementation of IPC practices, and core component 6 is monitoring and audit and feedback of IPC practices and activities. So while when we did these assessments, while the national authorities provided the the actual responses, the telephone interview allowed the evaluator the ability to describe the documentation that would normally be requested or reviewed during an on-site assessment, which, while it may have increased the bias in the responses, may also have contributed to some additional objectivity in the national authorities selecting them for their program, their IPC programs. So this slide depicts the introductory screen, and there were subsequent data entry screens that were completed in the Excel tool by the national authorities in the self-assessment. And in the context of the telephone interviews, the interviewer, the evaluator, input the appropriate given results into the data tool. And then at the completion of the interview, the Excel file was shared with the national authorities to allow them the opportunity to validate the data entry results, which were put in by the external interviewer. So as you may or may not be aware, the IPCAT is set up in a yes/no format. So in an all or nothing scoring scheme. So if something is completely implemented, then it is scored as a yes, and it receives a point for it. A partial implementation or a component or an indicator that has not yet been implemented is scored as a no, but notes can be made in the comment column to inform the action plan. And the comment section was very important, was and is very important in this tool, because what it allows for is for those components that are partially in place, it provides them something on which to build. And so they aren't starting from scratch. They aren't starting from zero of this. So, so also, as you can see across the bottom of the screen here, all of the different core components are set out in additional pages. And each of the pages contains the same format with the indicators, responses, and comment columns. And at the completion of this, the responses with a no response are highlighted in red, which allows for easy identification of the gaps. And in general, it's important to note that the telephone interviews took approximately 1 to 2 hours for the national authorities to complete, but it also allowed them the opportunity to be guided, to ask questions and to request more specific detail in order to allow them to provide the best response possible. These are examples of the summary pages that are found at the completion of the assessment. And so it shows the percentage within each component in which a yes has been achieved. That is what has been achieved. And so you can see by these examples, we're able to identify varying degrees of implementation. For example, we can see a program that's just beginning to be established, or that may have been established and has not been able to make progress, or one that has begun the process and is moving steadily through it, all the way up to one that is very established and in place. The second portion of the summary page provides a specific breakdown of the subsections within each core component, and it is accompanied by a radar graph, which provides visualization for the results for easier interpretation while highlighting gaps and achievements. These gaps, which were then identified within each core component, and as I've stated, they form the basis for recommendations and for developing suggested work plans. So this slide proposed work plan and what happens is the gaps, which were identified within each core component and showed up as red in the IPCAT tool, are then pulled out, and they form the basis for the recommendations, which are then transformed into a suggested work plan, which includes suggested timelines. And the color scheme on the right side of the screen allows the national authorities to visualize the possible resource commitments which may be necessary. And in presenting these work plans, we try to stress building on those components which have already been begun, but also using complementary resources, leveraging resources wherever possible. So the IPCAF at the health facility level provides program assessment at the health facility level, and this evaluates all 8 of the core components. So the original 6 components, as we saw in the national, as well as the 2 enabling environment core components that would enable a more fully developed infection prevention and control program. It's primarily aimed at acute care facilities, but as we stated, it can also be applied it can and it was applied during COVID at the primary healthcare level. The value of this is it's a standardized and validated tool for acute care facilities. And we looked at the entire scope of the assessment in the primary healthcare level, and we presented a cumulative score based on the entirety of it. But we also provided a focus on the primary healthcare level. We provided a focus on the minimum requirements that are defined in the 2019 publication by WHO, minimum requirements for infection prevention and control. So what's the advantage of using a standard and validated tool? Well, it allows the programs to not only evaluate themselves, but it also allows them to compare what they've achieved against not only the minimum requirements, but also it allows them to compare themselves against a worldwide benchmark. And so they can see based on their score and what level of implementation of an IPC program that's deemed to be according to the WHO definitions. It gives them something toward which they can work in the future, but also using it as an internal benchmark, they can compare their progress over time. So they can see when they are making strides in implementing additional IPC components, and they can also see where the program improvement has stalled, and they can look at the reasons why it's stalled, whether it's lack of resources or it's lack of commitment on the part of administration, or as we saw in COVID, they were sidetracked with other activities that, while IPC related, are not IPC program development related. So as I stated previously, this is an important tool because it allows programs to identify the strengths on which to build, as well as the gaps. And then it allows them to monitor progress sequentially over time. These results can be applied to develop specific facility-oriented action plans. And that's important because then they can aim their plans specifically as it relates to the services that are provided within their own facilities. So it allows this to be a tailored plan that is applicable to their institution and not just a generic work plan that may or may not have relevance within their health facilities. So the IPC, and it's also important, we stress with the health facilities that the IPCAP was not meant for routine comparison among facilities. And when we were assessing 10, 12, 20, 40 different facilities, we wanted to make sure that the results were not used in a punitive approach. We wanted to make sure that it allowed the facilities to identify where they had started, where they needed to start moving to improve their infection control programs. And so we used it we stressed that this was an internal benchmarking for comparison over time and not for comparison between one facility or another. So this is the first page from the IPCAF assessment portion of the document. The IPCAF is a paper-based program in this format. However, there is an electronic version that is available on the WHO IPC global portal. For our purposes, we based our virtual assessments on this paper-based tool. So we took the paper-based tool and we developed a Microsoft Forms version of this tool. The only difference was that we did not include the scoring system, and we did that because we wanted to allow the facilities to focus on the content of the indicator as opposed to the score. The tool could be completed on either a computer or other mobile device, allowing for increased portability. Although users who were allowed to do either, who were allowed to utilize either format, did comment that it was difficult to read on the mobile devices. We also had an Excel version of the tool, which was also used, which I will present following explanations of this format. So we added to the tool a facility demographics page. And the reason was it allowed us to determine the level of minimum requirements based on the type of facility and services that were offered. So this allowed us to tailor our recommendations and our suggestions to each facility or to a group of facilities based on the level of service that they provided, whether they were primary care, whether they were a primary, secondary, or tertiary care, acute care facility. So this, and within the survey itself, the survey was designed with branching, which allowed the assessor to be the person that was conducting this self-assessment to bypass indicators which did not pertain to the institution based on previous responses. For example, in the IPC, in core component 1 in the IPC program, if the assessor checked that the facility did not have an IPC committee, then the survey bypassed the questions that were related to the composition of the committee. And what this did was this alleviated conflicting or contradictory responses where they may say they have no committee, no ICC, no infection control committee, and yet they have senior management or clinical physicians involved in the committee. So it allowed us to alleviate some of those types of data challenges. Each question was marked as required, and the reason for this was that the person conducting the assessment could not proceed to the next section or the next core component without responding to all of the indicators in the current section. And this allowed the data set to be complete, and it left us without data gaps, as is sometimes seen in more traditional formats of assessments. As you can see with the light blue arrow, we included the suggested verifiers, and that allowed the assessor some examples on which to base their responses. So it gave examples of the types of documentation that would be used to support the response indicated. And the participants could enter the survey as many times as they required to complete the assessment until such time as they click the submit button. You can see that with the darker blue arrow at the bottom. And once they click the submit button, it finalized all of their responses and it closed access to the survey for additional changes. And as you can see at the bottom of the screen, bottom left of the screen, where it actually says that there are 112 questions, the content includes questions posed as subheadings, and it allowed us to section off the different areas or subsections within each of the core components. For example, in healthcare associated infections, there is a core component on the types of surveillance that are conducted. It contains a subcomponent or a subsection on methodology. So it allowed us to physically separate those areas in order to keep their thought train consistent with what we were requesting for them for assessment of data. And so at the end of it all, in actuality, we maintained the actual count of 81 indicators as is set out in the original IPCAF document. This is an example of the Microsoft Excel template that was designed like the actual paper-based IPCAF, and it included the associated scores for each indicator. This format was also applied as a self-assessment, so the assessor responded to each question by marking the appropriate score. So each section automatically tallied for the section score with a maximum of 100 possible scoring points, as is seen throughout the entirety of the IPCAF. So how did we initiate the process for this? Well, each assessment actually began with a virtual introductory meeting for the national authorities and other interested parties or applicable parties who are going to be involved in either or the IPCAT and the IPCAF assessments. So we provided full descriptions of the processes that were to be applied, the expected outcomes, that is the development of the work plans, and we discussed about the virtual support that was available during the actual assessment process. So prior to the initiation of the health facility assessment, all of the assessors participated in a 2-hour virtual meeting where we discussed each individual question, and then we presented possible verifiers that they could use to indicate if the indicator was fulfilled or not. And this virtual meeting was important because it laid out the framework for the conduct of the actual assessment on their own. So within the process, the introductory meeting, the discussion of the content on this slide and the next few that follow. So whether the country selected the paper version or the Excel version or the Microsoft Forms version or entered the data directly into the WHO IPC global portal, each core component has a series of questions or indicators, and each answer contains a weighted score. So it's important when they were completing the tool as a self-assessment to not overscore themselves, so as to get a more accurate picture or a true reflection of what was actually in place within the national program as well as within each individual health facility. We impressed upon both the national authorities as well as the health facilities that this is not a grade to be shared externally. It is a tool simply to assess their strengths and identify gaps that could be used for continued program building as well as improvement. And it's important to note that an organization's safety culture will play a key role in determining if participants or the persons conducting the assessment or participating in the assessment view this as an improvement exercise, or if they feel that they have to obtain the highest score, it means overrating themselves because there is more of a punitive type of safety culture as opposed to a that this is a systems issue and we need to fix it from a system side. So the safety culture is really important in how participants viewed the results and what was going to be done with the results in moving forward after the assessments were completed. We discussed how the assessment should be completed, and the key point, as I stated over and over, was the importance in selecting the answer which is most reflective of the state of the program, and then use the associated score for program advocacy with administration and decision makers. So in the preparatory meetings, we stressed some key points, such as answers that are difficult to answer may indicate a gap and should prompt in-depth discussion among the team completing the assessment. And we did stress that this should not be individuals completing these assessments, but that it should be done with a team from the facility in order to capture the broadest representation of possible components that apply to infection control, even though they may not be housed in an actual true infection control program. Unfamiliar terminology was referenced in the WHO guidelines on core components of IPC programs for them to further be guided. Each score component, as I stated previously, has a 100-point total. The weighted points are allocated to each question. The scores are calculated by adding the totals for each core component, and it was important for them to not alter or change the scoring when they were utilizing the Excel-based assessment, so as to allow us to adequately evaluate and assess the results and to provide recommendations. So this is a summary page for the IPCAF in the paper format, as well as in the IPCAF format, in the Excel-based format. And on the summary page, the subtotals show up in the appropriate rows for each of the core components, as you can see here, to obtain a total score at the bottom, as you can see here, compared to the maximum possible score, which was 800. So examples of graphics that can be produced for these results, entered into a simple Excel spreadsheet or other statistical program, help to visualize the results during the presentation and reporting phase following the analysis and of the assessment results. And then it allowed us to provide interpretations for the results against the benchmark that has been developed by WHO. And each individual facility could compare their total against the range of scores and determine the level of implementation that has taken place in their IPC program within their own individual facility. And so we provided this in each of the reports that we developed following the assessments. And the scoring interpretations provided basic guidance to each facility on the level of the program and suggested when a need for additional improvement to a greater or lesser extent existed. We use next steps to identify the strengths, as you can see in the middle column, and the weaknesses or the gaps on the right-hand column. And what we did was with the gaps, we also included those areas that had partial implementation. So it allowed us to at least assess to what extent that the component or the indicator had been initiated in implementation phase. It just may not have been completed. So if it's in place, is it fully or partially in place? And we listed them out for each core component based on the results of each individual indicator. So it is a very time-consuming process to go through and assess this. But in the end, it allowed us to list the strengths for those areas where the indicators were met to the highest possible level. And then the gaps listed those indicators that were met or not partially, that were met or only partially met. And the next step then was to develop an action plan. And this is an example of an action plan out of the WHO guidelines on core components of infection prevention and control programs. So we developed the action plan to correct the gaps. And it was important here that we made note of each of the key actions that were necessary in order for them to begin to improve that or close the gap that they had identified. So this is an empty example of the actual action plan that was developed. And again, this is from the interim practice manual supporting national implementation of the WHO guidelines on core components for IPC programs. We helped each individual facility, and we helped as a group for programs to develop action plans. We stress the importance of assigning responsibility, which is critical, because if nobody is assigned to it, it begins to fall through the cracks. So we stress the importance of assigning responsibility, as well as including a timeline in some way to monitor completion or achievement of that activity or gap. So the last part of the presentation, I would like to talk about the IPC, the monitoring of the IPC programs at the health facility level in the English-speaking Caribbean, which is the part in which I participated. So the demographics of the IPC assessments that were conducted, we conducted them in 3 English-speaking countries in the Bahamas, Belize, and the Turks and Caicos. We evaluated one tertiary hospital, 7 secondary hospitals, and 1 primary hospital, and we assessed 70 primary healthcare clinics. In looking at the achievement of the IPC assessments in the primary healthcare, this slide depicts the results that were found. In most countries in the English-speaking Caribbean, it's I need to make a note, IPC as a program has not really been formally implemented at the primary healthcare level. It is still mainly seen as a program within the hospitals. With COVID, we've had a recognition that IPC is just as important at the primary healthcare level as well. Thus, interest in assessing these pieces was already in place, and it gave us an opportunity to provide a step for them on which to build. Generally, IPC guidelines, workload, staffing, and bed occupancy, and built environment, equipment, and supplies for IPC scored the highest. The component score, the mean score for the IPCAF in the primary healthcare system was 331.9, which is a basic program. A basic IPC program implementation. The mean individual core component score was 41.5, so just below 50% of those suggestions. And that is looking at the assessment of the entirety of the indicators. This slide does not focus on the minimum requirements for IPC in the primary healthcare system. And the IPC assessments in the hospitals, as you can see, generally rated higher. The mean individual core component scores was greater at 70.4, and the mean IPCAF score was 563.4, which is an intermediate level implementation of IPC programs. And in comparison between the two, as can be seen in this slide, there's an obvious difference in the scores between primary healthcare and acute care hospitals, again, reflecting the need to strengthen IPC at the primary healthcare level, as this is the first point of contact for most patients. And during COVID, sometimes it also acted as a community amplifier for pandemic in some countries where programs were weak. And lastly, I'd like to talk a little bit about the challenges that we faced or that were faced and some of the recommendations that could be made in the future. The first one was that there was a tendency in self-assessments to overscore themselves. And we have seen this and it's been well documented in literature as well. But it's important to stress to the persons that are conducting it that this is not an opportunity to denigrate the hospital or the healthcare facility. It's an opportunity to identify gaps and allow us to help adequately design technical cooperations and assistance to help them build their programs to a better level. There was a tendency to focus on the score rather than on the indicator. So every facility was given a paper copy or an electronic version of the paper copy, so they knew what the weighted scores were for each indicator on which they were assessed. So we did see a tendency to focus on the score rather than on the actual indicator. And then lastly, one of the biggest challenges that we saw was the gap that was seen between the achievements in the acute care facilities versus the primary healthcare facilities. So when we look at recommendations, 3 of my recommendations are to focus self-assessments on indicators, avoiding the use of weighted scores during the assessment phase, not keeping the scores from them, allowing them to have them as reference, but in the actual conduct of the assessment, focusing on the indicator, so not having the score ride alongside the indicator, but just to present the indicator itself so that they can focus on the content as opposed to the score. The second one is to provide implementation guidance at the primary healthcare level, and WHO has begun that process with the tools that have been developed for implementation of IPC at the primary healthcare level that we saw come out during the course of COVID. And the last is to provide assistance, continued assistance to conduct assessments during the first 3 to 5 years after programs have been implemented. And this allows them to document, even if it's only baby steps, allow them to document the improvements that they're able to make as they begin to implement the work plans and improve their primary healthcare, or to improve their IPC programs, both at the acute care as well as at the primary healthcare level. And these are some of the references that are associated with this that I have done. And I would like to take this opportunity to say thank you for your attention during this brief presentation. And I will send this back over to Valeska. Thank you.
Oh, thank you very much, Kate. So colleagues, we had this wonderful opportunity and presentation to discuss the tool that we have to assess our IPC program at facility level, at national level, and that come very well together with the presentation from yesterday, where we discussed administrative indicators for the IPC program as a whole. So we have some questions here. So the first question, Katie, I believe you can see as well, if that's the evaluation tool that is online, if it's available in Spanish too.
The forms have not been translated to Spanish as yet, the ones that we used. However, if there is a need for that, there is a possibility for us to be able to do that. The forms, Spanish is an official WHO language, and therefore in working in the WHO IPC portal, then Spanish is an available language. And they utilize the same IPCAF tool in the IPC portal as well.
Okay, so the tools are available not only in the form format, but yes, we can work on it. So there is a question in the chat, and I will ask you to put your questions in the questions and answer, but I got to see this. If this evaluation tool is the same for all the healthcare facilities levels, I mean, secondary level, or hospitals, or primary care.
Yes, the assessments are the same. When it comes to interpretation, then your minimum requirements are what change, what should be recommended to be in place. So you may from a primary healthcare level score relatively low in the entirety of the IPCAF report, but when assessed for the achievement of minimum requirements that are recommended for primary healthcare, then the assessment often showed a much better implementation score. And so when we did the evaluations, we looked at both scores. So we actually marked every single indicator that was applicable to the primary healthcare level. And we reported the achievements at both levels so that they had an indication of where they stood with respect to primary care minimum requirements, as well as the total implementation of a very well advanced IPC program at any level.
Okay, thank you. There is a question about we make any comparison between the self-assessment and the external evaluation about the results, if it's comparable, or if we have compared the results.
We have not done comparative assessments as yet. We have only, we implemented these assessments during the course of COVID when everything was done in a virtual format, and we are only just recently beginning to conduct face-to-face training and assessments. So we hope to be able to do comparisons and be able to assess what was self-assessed as well as what was assessed with an external evaluator guiding the assessment process.
Thank you. There is a question. What does one have to do to get their program assessed? So if the country has interest in being assessed, so the Ministry of Health should contact PAHO at country level, the office, and request technical cooperation in infection prevention and control to do the assessment. So we already have some other countries that have made this request, so we are working with them to be able to do in the following weeks, actually, in other 2 countries' assessments. So it's through the PAHO country office. Ministry of Health is able to request, and we are able to provide this technical cooperation. So I don't know if we have any other questions or comments. I'm just scrolling here. So you have, so we apologize, but we're not able to send by email the presentation. So we put the presentations on PAHO webpage, as well the record for the meetings. So, and then we'll be able to access there. So during the course of the Kate presentation, I put the links for the tools that we have, and that they are all at WHO website, so you can easily access it through WHO website as well. And as Kate mentioned, some of them are translated to Spanish, not all of them. Yeah. Okay. So I don't see any other question. So then I would like to thank you, Katie. This presentation was really comprehensive, really easy to follow. So excellent presentation, because we know that this topic is really hard, discuss about the tools. I think you bring awareness that we have this invaluable tool to access, to do the self-assessment, to start to do our working plan. And if you need support, you'd like to have support, please contact PAHO, and we will do our best to provide the support. So thank you again. And thank you all who joined us today and yesterday. So I would like to, again, invite you to join us next week. Next week, we will have experience from Barbados about the assessment of practices in the isolation area for COVID-19. So thank you all to join. Thank you again, Katie, for the presentation. Thank you.
Thank you.
Bye.
Bye.